So, Bismillahirrahmanirrahim. Semua dengar? Yes. Nah. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So, I assume that everyone is here. So, let's...
Sure, Lina will
Oh.
be here in a while.
Oh, Lina.
Ha.
Nak tunggu ke? Terus?
Dia kata tadi start je dulu. Tengah
Okay.
prepare.
Okay. So, kita start dulu lah dengan majlis Umum Bukaan Al-Fatihah. So inshallah today we will this is a session for the procedure presentation. So inshallah we have divided and ourselves. There will be one procedure per one student, and we will start this evening session with supposedly Lina will be the first presenter, but Lina have problems, and we will proceed with Isha. Isha.
Hello, you guys can hear me?
Yes.
Because dekat screen laptop sini, I couldn't see anyone's video. So, sekejap, let me test. Can you guys see my screen? Nampak ke screen?
Okay.
Nampak
Dah.
Nampak screen?
Nampak?
Boleh
nampak.
Nampak ada botol semua.
Okay, alright. So I start first. Bismillah. So I'm going to talk on blood culture and sensitivity. So I'm sure that throughout this past 3 postings, ramai dah tengokkan blood and SNS kan. So just wanted to remind everyone that we do blood SNS because number one, because we suspect bacteremia, of course. We have especially when we found that the patient's temperature is high, more than 38 degrees, and then the white cell count is high. So the altered platelet count, so all these bacteremia signs. Sorry? Is everything okay?
Saya kat bilik Syak.
Sorry?
Sorry.
Teruskan.
Just kind okay. When we suspect bacteremia or when the patient has cytosis or any CNS alterations and other indications, so we do blood CNS. So of course, when we do blood CNS, first we have to gather everything. If you can see on the screen, the patient's information, the needles. In this video, it provides the butterfly needle, and then of course the sharp bins, all the disposable apron, the kit, the gauze, tourniquet, and mask, and of course culture bottles, everything that you need. But if you can see in this video, the culture bottles that they provide is two, one anaerobic and one aerobic. But in pediatric patient, usually we will use aerobic bottle only because pediatric patient, they are more prone to get aerobic infection. So it is to save cost, we only use aerobic bottle. Unless if we suspect an aerobic infection, then we do an aerobic culture too. So of course, you need to introduce yourself to the patient and you do the hand rub. You make sure that this is the right patient. You want to do the blood CNS. You open the dressing set and you lay everything out. And then you pour the chlorhexidine onto the cotton balls to be used on the patients later on. And then you clean the culture bottle caps using the alcohol swab. One bottle, one swab, must be using different swab. Oh, and then just to remind before you start using the culture bottle, just make sure that it is not contaminated. If the broth appears to be, then it means the bottle is contaminated already. So you position the patient, you find the vein, Make sure the patient is comfortable, and then you wear your disposable apron. So you perform surgical hand rub. You put on your sterile gloves, and then the chlorhexidine that you have poured on the cotton balls earlier, you clean the patient at the site where you want to puncture, and then you insert the needle. So in this patient, in this video, the doctor used butterfly needle. Usually in the ward, you could see that sometimes the doctor use needle and string only. And the aerobic bottle is filled first. If you are using butterfly string, then you should fill in the aerobic bottle first, because air might present inside the tubing of the butterfly string. So we don't want the air to enter the anaerobic bottle if we want to culture aerobic and anaerobic. But if you're using needle and string, you could just start with anaerobic first. Depends on what type of needle you use first. And then in this video, it says that you need to collect 10 mils of blood in each bottle, but this is because in this video the patient is an adult patient, so 10 mils each bottle. But in pediatric patient, usually we would withdraw 5 mil. Okay, we will withdraw 5 mil each bottle. And actually for pediatric patient, it depends on their weight. For preterm, infants, neonates, it depends on their weight, how much blood you want to withdraw. Like in preterm babies, usually 1 to 3 mil we do. Okay. And then after that, after you have take the blood, you remove the tourniquet, you remove the needle, and then you clean the site. You discard everything inside the sharp bin, and then you label, make sure that the information is correct, and you place everything inside the biohazard bag to be sent to the lab. That's all.
Okay, ada yang ada soalan nak tanya? Tak ada? So if everyone have question, you may ask. And I consider there's no question. And next we move to the second presenter, which is Husna.
Sahabat Irsyad.
Yes.
No question ya?
Sorry.
Clear semua? Tak ada yang tanya? Okay, so actually I forgot. Basically, the more basic one is about the hand washing and using PPE lah. Before every procedure kan, we must understand part of the infection control punya procedures, which is the most basic one is hand washing and PPE. Yeah. So you must understand the 7 step of hand washing. Not only know, but must able to do. Yeah. Okay. And then the 5 moment of hand hygiene. Yeah. So when we need to hand wash, so the 7 step is how do we do it? Using the soap and then washing the palm and then the between the finger, the nail, the dorsum hand, and then as well as the wrist, and as well as the thumb. Okay, and then the 5 moments you must understand. Yeah, so 2 before and 3 after. Yeah, 2 before the procedure like this, and then before touching the patient. After, of course, after the touching the patient, after touching the what we call it, collection, like fluid collection or anything from the patient, and after the another one saya lupa. Itulah. So before procedure like this, so is compulsory to hand wash. Yeah. Hand wash too. For ideal must use the water, but in case need quicker or availability of the shinky, maybe you can use the hand rub. Yeah. Okay. And then the another important part of the hand wash is the timing ya. So kalau following the procedure truly itu ya need at least 30 second lah, 30 to 60 second ya. Ada yang cakap dulu kalau boleh more than 1 minute, tapi I think 30 seconds should be enough ya. Should be adequate. Don't too fast. Kalau you are very fast and wash only 5 seconds, so it is not adequate ya. Okay, as well as the hand rub tuh. Nah, so nanti after this pun you need to review how to perform hand washing using water and as well as hand rub ya. It is little bit different technique step ya. 5 moment pun kena tahu, including this before procedure and then wearing PPE ya. In all hospital compound, later if you need or you are allowed to entering hospital, start from now we must use at least PPE level 1 PPE ya. Using despite the after hand washing you must use face mask nih. Even starting entering hospital you must use face mask ya, at all time. But for before procedure or before round you must use level 1 PPE ya. After face mask ya and hand washing ya, add on the glove and plastic to apron. Nah, itulah yang level 1. In case some body fluid risk procedure that have risk of bloody fluid like this, maybe and as well as yang non-confirm COVID case, maybe you need to do level 2. What more kalau aerosol generating procedures, you must use level 3. So kalau patient even procedure, but kalau patient dah confirm negative COVID, PPE level 1 should be okay. Okay, so go back now for the first procedure tadi ya, blood CNS kan. The key of blood CNS is must sterile ya, aseptic and sterile. So must use tadi yang penting tuh cover the area of the skin tuh, because we only sterilize the few part of the skin, so yang non sterilized part must be covered ya. Actually another ideal ya use plastic as well, so plastic cover and then baru prick, baru cucuk ya. Okay, and then sama lah tadi how to pull the blood tuh. Actually the the easiest one is vein puncture kan. Vein puncture terus aja lepas swab with alcohol and then pull out the blood, it's okay. But for the blood CNS tadi kena cover, yang penting tuh cover the surface ya, yang non aseptic or non sterile surface kena tutup tadi ya. Cuman yang open surface tadi, yang terbuka, yang tempat kita cucuk kena aseptic, kena sterile, kena sapu dulu, kena swab dulu, not only with alcohol, because alcohol actually can remove up to 99%, but still 1%. So must combine with tadi? Chlorhexidine tadi ya. Sometimes can be with povidone iodine boleh. Tapi lah kena 2 step ya. Different. Kalau vein puncture only 1 step je. Just terus sapu with alcohol is adequate. But kalau blood CNS kena sapu 2 kali ya. First with chlorhexidine, second with alcohol. Betul lah tadi? Kan terbalik ya?
Betul.
Okay, and then cover tadi. Because if we don't do this 2-step sterilizing and then not cover, so it is high risk to have kontaminan kan. Nah, so kontaminan itu will be difficult to assess lah nanti kalau every CNS keluar cons, coagulus negative streptococcus. Actually it is normal flora of the skin. So you must avoid that ya. Side of the another thing, side of the prick ya similar with vein puncture lah. The superficial vein yang nampak kan, the easiest one dorsum hand. Then can be apa nama fossa cubiti ini cubital fossa, and can be dorsum hand. The another one posterior medial malleolus. So many apa point, so many spot that you can pull out the blood. Any question or is nak tambahkan yang tadi ada a list of the location tak? Ke nanti ada yang IV line nanti? And vein puncture, Lina ya, oke. Okay. Lina ada join, ini dah ada Lina. Oke, okay. And then tadi dah betul ya, is aerob, simple ya. After pull out the blood, you must immediately push also the blood from the syringe to still with needle go into the bottle ya. Color apa untuk pediatrics, Isha?
Ya.
Untuk
pink.
patient. Pink? Iya ke?
Purple.
Iya ke?
Bukan aerobic bottle.
Coba tengok apa share je tadi screen tadi.
Sekejap.
Tak ada ke explanation tadi? Oh ya, you udah explain apa di ini semua nih, one by one apa keperluan satu-satu nih. Botol satu, label penting. Oke.
Label sudah.
The needle ini apa nama needle nih, dia apa tadi, butterfly ya. Oke, and then next apa lagi sebelah dia?
Apa dipanggil tu? Mak, saya lupa lah nama dia. Apa nama dia? Untuk tampal, saya tak ingat.
Taufiqnya dia. Oke, next lagi apa nih? Apron ya? Oh bukan, ini plastic cover kan?
Plastic cover.
Oke, then yang yellow one is the bin ya?
Sharp bin.
Oke, sharp bin. Needle kena masuk sharp bin ya? You cannot throw it into yellow garbage, tidak boleh yang yellow biasa. Yang kena sharp bin, yang kena ada proper cover to tutup close. So once you put in the needle or other sharp bin, you cannot grab it again ya, tak boleh ambil lagi. Okay, and then glove, and then the apa namanya, brush and set kan. And then gauze, and then apa nih, tourniquet, alcohol, mask. Yang in the apa? In the brush and set itu apa aja isi kat dalam situ?
Kat dalam botol tu?
No, yang di plastik, blue plastik.
Oh, dalam blue plastik.
Tu.
Semua ada cotton balls. So ada dia punya drip semua dalam tu. Untuk handle.
Itu ya. Okay, alright. Oh, go back to bottle lagi. Bottle can be orange, can be yellow actually, yang untuk pitch ni kita pakai.
Okay.
Ada biasa actually label in the bottle, on the bottle pun we can read ya, untuk pediatrics ya. Okay, clear?
Doctor, I have question. So in pediatric there is a specific bottle for pediatric, but what's the difference compared to the adults?
Usually the media similar ya, aerob media. The specific size pun actually lebih kurang sama, but yang different tuh actually the composition amount of the content to the media, and then the blood that we need to enter, we need to pull in ya, we need to we need to enter the di botol tuh. Because kalau tadi kan in adult sometimes sampai 10 ml. Kalau in kids berapa tadi Isha?
5 mil.
5 ml pun adequate. So memang half of the amount of the adult punya sampelnya. So yang kat dalam pun the media pun dia composition pun will be around half of the adult. So you need to enter the amount of the blood until certain level. Level tu ada kat botol tu ada line kat situ, ada garis yang you boleh nampak. So kena masukkan amount of the blood sampai achieve the level of the line tu. Because should be specific less amount half because what more kalau in pediatrics maybe not many issue, even sometimes issue in overall children it is difficult to get adequate blood, sometimes to get adequate good vein pun susah nak pull out adequate blood susah juga in certain condition. What more in neonates, kalau in neonates despite difficulty we must always remember the total blood in circulation. So kalau you ambil adult tu kan around 50 kg, the blood tu around how many ml per kg? How many percent of body weight? I think in adult tu sampai 5 liter kan the blood.
5 liter.
3 to 5 liter kalau tak silap. If I'm not mistaken, around 100 milliliter per kg kan, the amount of the blood of every of the human tuh. Okay, so maknanya kalau 50 kg, so dia boleh sampai 5 liter kan, 5,000 ml. So kalau neonates you can imagine only 3 kg. What more kalau preterm yang only 1 kg. So amount of the blood, total blood of the body only 100 ml for example, 100 milliliter, 100 cc. If you take 10 cc like in adult sample, so it is 10% of the preterm baby. So you take 10% of the blood in the circulation, the baby will have 10% fluid and blood loss. So udah ada flop shock. So shock to started from the 10%. Severe dehydration to 10% kan, 10% fluid loss, blood loss. Usually kalau yang definitely shock to more than 20% baru betul-betul shock, tapi 10% udah early. It is dangerous if you take 10 ml from 1 kg preterm babies. Yang term babies pun only 300 milliliter. So usually the safe tuh kalau we take the blood tuh not more than 3% of the total blood. Kalau more than 3%, udah develop some symptom, patient udah dehydrated, boleh develop shock and so on and so forth. Next, anything? Okay, if no, we go to second presenter.
Bismillah, my name is Taufiq and I will share about the nebulization. So, what is nebulization? Nebulization, it is a therapy that delivers the respiratory drug directly to the lung. And the nebulizer, this device, is a device that can convert a liquid solution or suspension into aerosol droplets suitable for patient inhalation. So, next, what is the drug type that used in the nebulization? The first is bronchodilators that can be used to treat the airway obstruction, the antibiotics used to treat the infections, and also mucolytics such as the hypertonic saline or normal saline to treat for any abnormal situations. And some of the indications of nebulizations include the bronchial asthma, bronchiolitis, cystic fibrosis, laryngeal bronchitis, which is croup. Next is the components of nebulization. It consists of the driving force, the tubing, the nebulizer, and also the delivery system. The driving force is the supply of pressurized gas, which can be either air or oxygen. So, air or oxygen. And for the tubing, which is the hose that can convey the compressed gas to the nebulizer. And next is the nebulizer, as I mentioned before. It can convert the liquid into air droplets. And there is a chamber that used to put the medication. And also last is the delivery system, which can be the mouthpiece or the mask. So there are two types of delivery system, which are the mouthpiece and face mask. And the advantage of the mouthpiece is there will be no leakage, and there will be no deposition in the nasal passage or face, and it has more efficient of drug delivery. And for the face mask, it is easier for patient to use, but the drug can be deposited in the nasal passage or face. So for the procedure of nebulization, I will explain this on this video. First of all, we need to ensure the correct patient positioning. So the ideal patient positioning is 45 degree. It is to ensure that the nebulizer is in vertical alignment, because if the medication is tilted, it can move away from the jet gas port. So the medication cannot be delivered efficiently. Okay. Next, we will connect the tubing to the oxygen source. The oxygen source can be the oxygen or air or heliox, and the oxygen is the most commonly used if there are no contraindication, because it is the most readily available compressed gas in most institutions. And we must make sure that gas flow is off when connecting the tubing. It is because to reduce the wasted drug and also increase the receipt dose. And next, we will load the medication in nebulizer and replace the cap and attach the interface to the mask or to the tube, and attach the oxygen tubing to the nebulizer and place the mask to the patient, and turn the oxygen flow rate to 9 liters per minute or any recommended, and the treatment time is usually 10 to 20 minutes. I think that's all. Thank you.
Does anyone have question?
Ini nebulization only ya? Yang tadi yang aero chamber lain lagi? Different presenter sama?
Different.
Oke, ada. Oke, question dulu.
So I have a question. So just now you said that there are three sorts of gas, which is medical air, oxygen, and helio. So when do we use medical air, helio, and others?
Sorry. We usually use the oxygen for the record from especially from the hospital pipeline, and we can also so the most common use is the oxygen. I'm not so sure and the air is usually I'm not so sure about the heat thing.
Okay, yeah. So yeah, availability and apa isi apa di accessibility as well ya. Usually kalau hospital kan memang apa nama using oxygen port. Heliox tuh ada someone yang kena apa? Kena mute dulu nih. Husna nih. Husna ada presenter ya? Bukan kan?
Saya present.
Kata tadi Lina tak jadi ya? Oh, okay. Alright, so usually kan the easier way to access in the hospital will be presentation jangan buang dulu. Nanti tak review sedikit. Usually yang easier is oxygen kan, and as well as more effective actually because if we use oxygen, actually despite we nebulize the patient, actually we also oxygenate the patient, give 100% oxygen. Different with if we using machine. So yang slide number 4 tuh. Kalau using machine, number 4, slide 4. Slide number 4 betul ya? Kenapa lain? Ya betul, sorry. Kalau using machine like this, only air kan, only 21% oxygen. So we give only room air oxygen, room air. So no additional treatment. If we use oxygen port like in the hospital, we give 100% oxygen as well. So it is actually 2 treatment. Ya. Kalau yang pakai Helios pakai oxygen tank tadi kan, usually kalau more on transport punya mekanisme, we need the oxygen tank lah, because using machine pun tak boleh ya, because the machine oxygen port with tank kan kena transport. Kalau using machine must have fixed plug ya, kena electrical plug, dia kena fix lah, tak boleh pergi mana-mana ya. Okay. About this slide ini, another thing yang penting is the the nebulizer itself nih, yang chamber with medicine cup. So don't forget the medicine cup usually have specific color, usually green lah, ada yang color lain maybe. You must put it on the right way, because or you must put is one thing, the second thing you must on the right direction. Kalau sometimes terbalik atau tak letak, so the jet process, the system will not in place. Yang penting tuh yang medicine cup tuh. Kalau tak ada medicine cup ya tak jalan lah di jet nebulizer process tuh. Okay. And then tanya biasa kan common question actually, how many amount of fluid need to be put in the chamber? Siapa tadi? Husna.
I'm not sure, Doctor. I'm not sure, Doctor.
Ada yang lain? Ada. Biasa selalu tanya aja orang. Tanya kan, why need to add on with normal saline, or can we use pure 1 ampule of for example Ventolin, salbutamol. Tahu tak? Yang lain, others? Tak ada yang tahu ke?
I'm not sure, Doctor.
Tak ada. Usually, amount of tadi kan, the effective nebulization ini 10 to 20 minutes kan. If you only give 1 ampule, Usually it is 2 ml lah. Paling ada sometimes yang 2.5 standard ampule of the drugs tuh. So only 2 ml tuh will lasted very fast. Nah. Maybe 5 minutes pun udah habis. So what more if you use tadi, coba tengok slide number 5 tuh. If you use face mask, so ada some apa namanya leakage kan. So jadi rugi lah kalau pakai only the medication. Usually kalau less than 3 ml usually we add on lah. Kalau macamnya 1 ampule only 2 ml kan we add on at least 1 ml. But can be also sampai total 5 ml. So 1 ampule plus 3 ml. Tapi usually my style tuh it is preference kan. My style ya supaya senang give instruction to the nurse to the operator, give 1-to-1. So 1 ampule Ventolin 2 ml plus 2 ml normal saline, so 1-to-1. Jadilah total 4 or 5 ml ya, inside the chamber. So we'll have adequate aerosolation, adequate with jet process, jet nebulizer, aerosol itu adequate in 10 to 20 minutes. Kalau yang this number slide number 5 ini kalau using the mouthpiece it is more effective, but in children it is usually difficult kan, because need to use proper understand the instruction, the patient tuh must use the mouth breathing. In pediatric pun, in children pun nak letak face mask pun susah, apalagi nak suruh patient breathe in the mouthpiece pun lagi susah lagi. Kalau face mask tuh even though we just put in front of the baby, it is possible lah to have some effect of the nebulizer. Oke, slide number 6 tadi apa? Tak nampak sangat. Coba tengok.
Saya terus explain yang dekat video.
Inilah yang penting tadi, yang chamber tuh match medication into the cup tuh. Cup tuh ada penting kena ada yang macam cone tuh. Yang cone tadi yang saya kata color green, ini color tak nampak pula. Ya ini green lah, sama lah. Yang green tuh lah the cone tadi. Oke. Video tadi dah clear semua? Nak repeat balik ke tak? Ke ada yang tanya lagi? Oh iya, lagi yang first tadi betul kan, kena vertikal ya. Common mistake kan. Patient kan in sleeping position, in supine position. And then sometimes ada tuh pernah saya tanya, dan terus letak aja di nebulizer in supine position, jadinya horizontal lah di yang ini di cup nih. Di chamber jadi horizontal. So jadi ini yang clear nih. Jadi the medication, the fluid jadi tilt away from the jet gas port. Jadi tak keluar lah aerosol tuh. So mask in vertical position, memang need the patient at least 45 degree, if possible ya sitting position. Or if sleeping pun not in supine, dia kena what we call it, decubitus position, lateral position. So we can put the chamber, the jet medication cup to in vertical position. Okay. Nah, any more question? Boleh nak habiskan kan, nak stop ni? Tak stop ya. Okay lah, alright. Okay, can continue next presenter.
So we move to the next presenter. The next presenter will be Azri.
Nah, tadi tak jadi ke?
Yes, Doctor.
Lina tadi tak ini.
Lina will be last presenter.
Jelas, oke lah, alright.
Dah.
Yeah. Okay. Semua nampak ke?
Nampak.
Alright. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I will present to you about the intubation in pediatrics. So this is my outlines. First is the definition of the intubation, the indication for the intubation, preparation for intubation, and also how to intubate patient in the pediatrics. Okay, so what does intubation means? Intubation means the insertion of a tube in patient's body, especially that of an artificial ventilation tube into the trachea. So it means that you put a tube, an artificial tube, into the trachea through the vocal cord for ventilation purpose, to help ventilation purpose. So I took this definition from the Oxford. Okay, so for the indication, okay, the first one is patient with unstable airways, such as patient with URTI, malignancy, and also URTI, malignancy, and also traumatism patient. So the airway become unstable, so it logical dysfunction where the patient cannot control the airway, the opening of the glottis. So due to secondary to seizure and also trauma. Okay, and third one is impaired gas exchange. The first one is for hypoxemia. Okay, usually the patient has respiratory distress and present with tachypnea. Okay, the second one is due to hypercapnia, which is increase in CO2 level due to VQ mismatch. Okay, and then the last indication for intubation is lower airway obstruction, such as asthma and also bronchiolitis, acute bronchiolitis. Okay, next is preparation for intubation. There are two steps. The first one is preparing the patients, and the second one is preparing the equipment. For the preparing the patient, they are divided into 5. The first one is pre-intubation assessment, which you need to access the anatomical pathway. Means that there is microglossia or there is any abnormalities on the face, so that it will make the intubation to be difficult. And the second one is cardiovascular. So you need to monitor any cardiovascular defect, because administration of the anesthetic can induce cardiovascular collapse. And situational, you need to check your team and also all the equipment are ready for any emergency situation to occur. Okay, and then the second one is fasting. We use the 2-4-6 rule: 2 for clear fluid, 4 for breastfeed, and 6 for formula milk rule, which you need to ask a patient to fast because it can reduce the risk for aspiration. And the third one is oxygenation. You need to give enough oxygenation, which is 100% oxygen to this patient, because it can increase the time for desaturation and also the time for intubation process. So you can have more time to intubate the patient. Okay, and then the fourth one is positioning. You need to have a good positioning for intubation, which is sniffing position. This is because, as you can see from the picture, when you move the patient in sniffing position, the airway will become straight. So it will easy for you to intubate the patient. And the last one is reliable IV access, where you can administer, you need to administer the drug or the medication in the patient. Okay, and then the second one is preparing the equipment. The first one, you need to monitor the SpO2 through pulse oximetry and also ECG. You need to check any cardiac abnormalities. Okay, and then you need to give the oxygen. Face mask, you need to have an ideal face mask which cover the chin, mouth, and also the nose. If it is too big, it will induce leakage, and if it's too small, it will not get enough oxygen. Okay, and then the fourth one is suction. So you need to have suction nearby you so that you can suck any aspiration from the stomach and also blood and also vomiters. Okay, and then for the endotracheal tube with stylet, stylet is the one that stiffens the endotracheal tube so that you can easily intubate the patient, while the endotracheal tube divided into two. The first one is cuff and or uncuffed tube. Okay, for the cuff, there's presence of ballooning. As you can see, there's presence of balloon in front of the cuff, while the uncuffed, there's no balloon. Okay, so why there's different for endotracheal tube? Because usually uncuffed is preferred by the pediatrician for patients under age 8 years old. Okay, this is because of the narrowing part of the larynx, which is funnel shape in pediatrics, while the adult is cylindrical. Sorry. So there's presence of narrowing part at the subglottis area, so that if you use the uncuff, it will directly enter the subglottis and fits there. If you use cuff, you will induce more pressure on the narrowing part, subglottis area. Okay. But the cuff endotracheal tube is important to, it's the advantage of the cuff endotracheal tube is for reduce the aspiration, the risk for aspiration. So for the uncuffed ETT sizing, we need to use the formula where the age of the children divided by 4 plus 4. So you will get an ideal sizing for the ETT, endotracheal tube. Okay, and then for the laryngoscope, there are 2 types, MAC and the Miller blades. For the MAC blades, as you can see, this is MAC, this is Miller. The MAC is curved, while the Miller is straight. Okay, the MAC, usually it will indirectly open the epiglottis by put pressure at the vallecula, So it will indirectly opening of the glottis, epiglottis, while if you use the Miller, it will directly open the glottis. Okay, that's the difference between MAC and Miller. So why there's different in laryngoscope? Because in pediatrics, usually we use the Miller blade as the epiglottis is floppy in children. So you need to directly open the epiglottis. If you use the MAC, it will not open because of the floppiness of the epiglottis itself. Okay. So next is forceps. So we need to use this forceps to remove any obstruction in the airway. Okay, so how to intubate? Okay. Oops. Okay. So I will show you the the video from the YouTube. So do you guys can see the video?
Yes, yes.
All right. So firstly, basically you need to monitor, like I said mentioned before, you need to monitor the SpO2 level and also the cardiac abnormalities and also the oxygenation in this patient before intubation. Okay, and then you need to move the position. You need to position the patient in sniffing position as to allow the airway to become straight. Okay, and then after it's straight, you will use the Miller blade for the pediatrics. So you will enter the mouth. Okay, enter at the right side of the mouth, and then you need to sweep the tongue so that the blade can enter the midline. Okay, understand? Okay, and then you need to lift up your blade, not to flex. If you flex, it will induce damage to the mouth of this patient. Okay, so you need to lift up until you can look at the epiglottis and also look at the epiglottis. So when you see the epiglottis, you need to move the Miller blade in front and lift up the epiglottis so that you can see the opening of the vocal cord. As you see the opening of the vocal cord, you need to ask your assistant to give you the endotracheal tube so that you can enter, you can insert the endotracheal tube into the vocal cord and into the trachea. Okay, after you, sorry, the explanation is too fast. Okay, so use of the Miller blade. Sorry, because the video is not functioning very well. So I just will explain. Okay, after you induce the intubation, after you insert the tube inside the endotrachea, inside the trachea, you need to remove the blade slowly. Okay, and then you need to hold the tube and remove the stylet. Then you need to connect the endotracheal tube with the face mask and also the ambu bag. Okay, after you connect that, you need to ask your assistant to pump and you need to observe the chest expansion and also you need to hear the breath sound on the bilateral side of the lung by using stethoscope. So basically that's all for intubation. Sorry for the video. Sure. Sorry. I will share the video with you guys later. Okay, so this is basically the. Let me see.
Yep.
Yeah. Just for one. Okay. Sorry. I don't know, but I already changed the slides, but from the video presentation is still ongoing. Okay, try. Can you guys see the slides? No?
No.
That's all right. Okay. Hmm. I'm not sure why, but I cannot share with you guys the slides. So basically, my next slide is I explain back how to intubate patients in words. And then for the complication, it's okay. I will just explain to you. And then for the complication of intubation, the first one is the upper airway trauma, tooth avulsion, oral pharyngeal laceration, hematoma of the vocal cord, tracheal laceration, perforation, and intubation of the esophagus. Basically, the intubation, the complication for intubation are divided into uh, in intra during the intubate and also after post intubation. So I just mentioned to you guys the complication of intubation in general. Okay, so basically most of the complication is due to intubation itself, usually due to mechanical injury. Okay, due to mechanical injury. So can you see? No. Yeah. Oh. Hmm. Tak boleh ah. Yeah, so anything. Just for a while. Hmm. 8946 8946 714 1175. Finish meeting. Join the function. Okay. Okay.
It's black.
Finally.
Ya, nampak.
Okay. So how to intubate for the video I will share with you guys later. So basically this is how to intubate. First you need to check for functioning IV line, oxygen saturation, and also monitoring the cardiac and SpO2. Okay, before administer the before the administration of the medication. Okay, and then you need to do the head positioning, which is sniffing position. And then you need to place Miller blade at the right mouth, sweeping the tongue to the left and lift up the tongue in an upward position. Okay, so you need to look for the epiglottis. Okay, then lift up the epiglottis as you to see the opening of the vocal cord. Then you need to insert the ETT into the trachea through vocal cord and then remove the blade. Hold the ETT on mouth, remove the stylet and connects with ambu bag and also face mask. Then after you connect with the ambu bag and face mask, you need to observe the chest expansion and also hear the breath sound at the lateral side of each lung with stethoscope. So like I mentioned previously I mentioned complication of the intubation, upper airway trauma, tooth avulsion, oropharyngeal laceration, hematoma of the vocal cord, tracheal laceration, perforation, and intubation of the esophagus. All of this usually due to mechanical injury of the intubation itself. So next is the Malipati score. Malipati score are divided into 4. This score is for predict the ease for intubation. Okay. So class 1 is complete visualization of the uvula, visualization of the base of the uvula, and class 4 is soft palate is not visible at all. So that's all for me. Thank you. So for me.
All right. Questions?
Any question?
Tak ada lagi. Tak penat lah. Baru 3 ni kan. Aduh, nanti after 5 we take a break first lah. So 2 lagi ya. So yang ini intubation sama lah nanti. Aziz already give details about the technique and so on and so forth. As at least you understand how to perform lah. For the skill memang need opportunity first and then 2 is practice lah. If you don't have opportunity and don't practice, you will not able to do. Even it is not your competency as medical student ya. Usually in housemanship lah baru you belajar. Okay, alright. Okay, thank you. Next.
Sorry, doctor. Sorry, guys, for technical problem.
So next, I will be presenting. Semua nampak skrin?
Nampak.
So Bismillahirrahmanirrahim. So I will share to you about the mesogastric or gastric section in pediatric. So these are my outline. So the introduction, what is the definition of the NG tube? It is a long, thin or hollow tube which is passed through a nostril, mouth into the throat and down into the stomach. And there are several indications that I have listed. I listed 3. So the first indication is it is used for the nutrition or feeding. In the case in which if there are
sorry to interrupt. Itu yang your background TV sound tu tak boleh kecilkan ke? Ke mana?
Oh, okay, yeah. I try to find another place. Yes. Sorry. So I will continue the presentation. So like I mentioned earlier, the first indication is it is used for nutrition or feeding. And the second one, it is used for the medication administration. And basically, the first and the second indication, it is used in the patient if the patient is have poor mental status and it have in poor appetite, so we can use this alternative. And the third one is evacuation of the stomach content. So for this part, if there is injection of recent injection of the toxic material, we can use NG insertion to evacuate the toxic material. So next. So before we start or begin the insertion of the tube, there are several contraindications of the NG tube. So for the first one, if there is a fracture to the vessel or fracture of bacilla, Basically, this one it is because if there is fracture, it might cause the tube to go to the brain, to the brain part. And for the second one, if there is a clinical disorder of esophagus or stomach. For example, esophageal ataxia, esophageal or gastric perforation, and and we must avoid this condition. And we also need to give more caution in the patient who have esophageal or gastric varices, the patient who receiving anticoagulant therapy and thrombocytopenia. This is because we need to avoid any injury that can cause prolonged bleeding and excessive bleeding. So next, for the procedure for the NG tube insertion, first I have divided into three parts, which is the first one is for the preparation of the tube. So for the preparation, we must prepare the tube, prepare the equipment, and I have provided the
Hello?
this is the picture. So you can see that there are 2 points. So the first one, you need to hold the tube to from the nostril to the base of the earlobe, and then to the halfway between the base of the chest bone and the umbilicus. So this is the picture. You can see that. And then after that, after we had confirmed the measurement, the length of the tube, we can mark the point on the tube with the permanent marker. Then after we had confirmed it, and now for the insertion process. So for the position, we need to place the patient in semi-upright position. So for the maybe older children, we can ask them to lie on the back at the 45-degree angle. And for the baby or young children, we can put at the mother's lap, like the picture. So next, as
Hello? I think apa the internet problem ya Irsyad nih.
Mungkin
sekejap, nampak? Sekejap semua. Sorry. Okay.
Ah.
So why we need to ask the patient to sip the water? It is because to ease the swallowing process of the tube, and that's after we had confirmed and successfully insert the tube, and we need to secure the tube to face with a tape. And during the insertion process, we need to be alert if the patient shows a sign of respiratory distress, such as if the patient had excessive coughing, the patient has trouble breathing, it might indicate that there is a accidental placement of the NG tube in the trachea. So what to do? We need to remove and pull out the tube, and we let the patient to recover. So next. Okay. So after we successfully place the NG tube, we need to confirm the placement of the NG tube. So there's 3 ways to confirm the placement of the NG tube. So the first one is we need to instill the syringe with air and connect the syringe to the tube, and we instill the syringe and we listen for the gushing of air. So we listen by using stethoscope. If there is gushing of air, it means that the tube is at the right place. And for the second one is we can use pH expression. We use the shrink to express the gastric content, and the gastric content can be tested on the pH strip, and we see that if the strip show that the pH is below than 7 or in acidic value, it means that the NG tube is at the right place. And last but not least, the abdominal X-ray. For the abdominal X-ray, basically it is used in high risk patient, such as if the patient is in coma or like what's lah. So last for me about the complication. So there are 3 complications that I have listed. So for the first one is nasal or gastric bleeding. The second one is so for the nasal or gastric bleeding, it is might due to mechanical injury. And for the second, esophageal or gastric perforation, it is rare complication. But if the patient have predisposed condition that have esophageal or gastric defect, then it might lead to the perforated esophageal or gastric. And last but not least, sinusitis. So why sinusitis? Because if we put the tube for the extended long period, and it might lead to the damage to ciliary epithelium, and it will cause infection and will lead to sinusitis. I think that's all for me for the part of NG tube insertion. These are my reference.
I have a question. Okay. For example, like in adult, if you place NGT tube in the patient, you need to ask the patient to swallow, right?
Yes.
Okay. So if in pediatrics, is there any ways or any cara untuk masukkan like swallowing juga macam tu ke?
So supposedly, if the patient can drink, we ask them to drink lah.
Okay lah. So the problem kan children cannot follow the instruction. So that lah some technique ya while the baby masa dia telan tu sama je kan. Sama dengan swallowing ya. When the baby swallow the milk, so we enter. The second thing actually, when we do nasogastric or orogastric insertion tu, actually the physiologic punya apa nama dia, physiologic punya route, it will always entering the esophagus other than entering the trachea actually. Because esophagus, what more if in supine position, esophagus is in the posterior, so it will be very easy to enter the esophagus because there is no the position one, and then second is no epiglottis to that make it difficult to enter kan. Kalau if entering the epiglottis, it will be more difficult than the esophagus, but still always possibility to enter the trachea. So that's why if there is some response of choking, coughing, so we pull and reinsert the tube.
Thank you, Doctor. Yeah. There is other question.
No, Irsyad.
The size yang tadi siapa? Irsyad, you ada explanation of the size tak? Size number 3, number 5, number 8.
Apa, Doctor?
Size of the tube.
Oh, size. I do not include the size.
Okay lah, you can learn more lah. Usually the smallest usually number 3 lah, but number 3 itu only for fluid lah, cannot for apa nama porridge. Porridge lah. Jadi kalau for porridge number 3 for neonate, kalau term infant usually using number 5. In bigger child number 8. Okay, next. Ya, alright.
Okay. So next apa? Fariha.
Tak dengar mic tak?
Hello Fariha, can you repeat? We cannot get your voice kan?
Tak dengar suara Pak.
Nah itulah. Kalau if we see in the participant punya apa list ni Fariha dia memang keluar suara, tapi lah tak masuk ke kita. Or can anybody, Fariha, can you stop? Can anybody have Fariha to share the screen and Fariha only sound? Boleh tak kalau macam tu?
Ni, Fa cuba cabut earphones. Takut earphone yang problem.
Betul. Fariha, can you repeat?
Tak dengar jugalah. Nampak dia punya mic bergerak. Setting mikrofon dekat Zoom tu on tak Fa? Mikrofon dengan speaker setting.
Or can we, Mas Irsyad, can we go for the next presenter first? Let Fariha nanti settle her problem.
So next presenter, okay. Next presenter would be Taufiq.
Assalamualaikum warahmatullahi wabarakatuh. Can you guys see the screen?
Yes.
Okay. Can you guys hear the voice? The
Yes.
audio here. Oh, you can hear. Okay. Before I start, so I will because my video takes 11 minutes. So I will explain in the background of the video. Is it alright for you all?
Okay.
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 So I will try to make it as fast as possible. Okay. Let's get started. So principally, lumbar puncture is principally the same for adult and children, and there is several indication of lumbar puncture, which is it is indicated for both diagnostically and therapeutically. So the cerebrospinal fluid obtained from the lumbar puncture can be used to identify the etiology of the disease, whether it is infectious or inflammatory or oncology or metabolic disease. And it also used in spinal and epidural anesthesia by intrathecally inserted into the cerebrospinal space. So therapeutically, it can chemotherapeutic agent and antibiotic can be inserted into the spinal canal or in the cerebrospinal fluid. So there is several contraindication for lumbar puncture. It is contraindicated to the patient with cardiorespiratory compromise because due to the position during the procedure. And it is also contraindicated if there is signs of cerebral herniation or focal neurologic signs, or to the patient with bleeding diathesis or the patient with previously undergone lumbar surgery. So if there is a sign of increased intracranial pressure or in neurological assessments such as papilledema on fundoscopic exam or in the result of the CT scan, the patient is contraindicated to do the lumbar puncture. And then if the patient have taken anticoagulant therapy or have coagulopathy, the patient should not have the lumbar puncture because it can cause spinal hematoma. So this is the patient with previously undergone lumbar surgery. So that's all for the contraindication. So let's proceed to the equipment of the lumbar puncture. So usually in the hospital, the equipment is all packaged in one set. So the equipment include sighted spinal needle 20 or 22 gauge, skin prep and drape, coalition tubes, and manometer. So the needle, we use dilated spinal needle, and it is the length of the needle correspond to the child age. For the infant, we use 1.5 inches. For the child, 2.5 inches. And for the adult, 3.5 inches. And do not forget to use sterile glove. So for positioning, there are two positioning can be done in lumbar surgery, which are first, lateral recumbent position. The left one is lateral recumbent position. And the right one is sitting position. So lateral recumbent position is preferred to obtain accurate opening pressure by using the manometer, and to get a widened gap of the space between the spinous process. So as you can see here, the patient have to assume a fetal position or cat position with well flexed back to make sure that the gap between the spinous process is wide enough to so that the needle inserted would not hit the bone. So in sitting position, the spinal axis is perpendicular to the back, and in lateral recumbent position, the spinal axis is parallel to the back. So usually in lateral recumbent position is preferred than the sitting position, because it is believed that it can reduce the post-puncture headache. So a visual line is drawn between the superior aspect of both iliac crests, and then it intersects at the midline at L4 at L4 spinous process, and needle will be inserted between L3 and L4 or L4 and L5, as long as it is below to the termination of the spinal cord, which is conus medullaris, as you can see there. So the cauda equina is a strand of nerve root. And then not to forget, we have to palpate the insertion site. And mark it with pen. And then for the preparation, we have to make sure that to apply chlorhexidine or providone iodide to make sure the site of the incision is sterile. And don't forget to apply the drape, as you can see there, to make sure only small window is visible. And then don't forget to arrange the tube in order of a priority. And then we give subcutaneous drug. I'm sorry, subcutaneous drug, or it can be anesthetic. Subcutaneous drug, or it can be inserted in IV line, or even it can be inserted topically. So for the insertion, we have to make sure that to identify the site of the lumbar puncture. So it will be between L3 and L4, and make sure that when we inserted the needle, it is 15 degrees, and as if we aim it toward the umbilicus. And the bevel of the needle should be in sagittal plane to the dural fiber sac, so that we separate the fiber rather than cut it. So if properly positioned, the needle should be passed to the skin and subcutaneous tissues. Second, through the supraspinous ligament. Third, interspinous ligament. And then the ligamentum flavum, where we hear the pop, and posterior epidural space. And then dura, the arachnoid, and then the subarachnoid space, and then through the nerve root. As you can see there, the needle is inserted into the subarachnoid space between the needle roots. So when we hear the pop sound, we withdraw the stylet and see whether there is flow of the fluid. If we do not get the flow, we can withdraw the needle up to the subcutaneous tissues and then redirected it again. And then check if there is a flow. If there is a flow, then the subrenal fluid can be collected. So if you find out that the flow is obstructed, you can turn it 90 degrees, because there is some nerve root obstructing the needle. And if you found out that there is blood in the needle, there might be a coagulation that obstruct the needle, so you have to replace it with another one. So this is the measurement of the opening pressure. So typically the opening pressure would be below, if more than 25 centimeter water, usually we have to make sure that there is no sign of increase elevated of transcranial pressure. So as you can see that we connect the flexible connector and attach it to the manometer, and then connect it to the hub of the needle inserted, that have already inserted. So we wait the rise of the water column in the manometer until there is pulsation of cardiorespiratory motion. So that's when we take the measurement. So for specimen collection, this is, as you can see here, that here we take the specimen. The specimen have to be taken as minimal as possible. That is necessary for diagnostic. That is necessary that is necessary. And then when you have collect all the specimen, you insert back the stylet and then withdraw the needle, and then make sure that the patient is lying flat to reduce the post-puncture headache. However, there is not enough evidence that prove the benefits. So after that, we put the sharp into the sharp container or sharp devices, sharp container devices. And there is some challenge faced where during the lumbar puncture, where in obese patient, it might be difficult for us to determine the lumbar puncture site. And in also osteoarthritis or sacroiliitis or ankylosing spondylitis or kyphoscoliosis, or even in the previous to the patient with previously undergone surgery. So for this type of patient, referring to the anesthesiologist or radiologist should be a best approach. So there is some complication of the lumbar puncture, which first, there might be herniation of the brain. There is pain, headache, bleeding, infection, subarachnoid epidermal cyst, and CSF leakage. And if there is presence of the increase in to avoid that complication, we have to do thorough examination and neurological assessment before doing the procedure or during the procedure itself. And that's all for me.
Alright, so basically the level lah yang important ya. The technique more or less the same with blood CNS ya, must be aseptic. Dia two step of the sterilization, and then must covered with plastic and or some cotton there. Okay, but the injection tu yang the degree of the injection yang lain sikit ya, the needle pun lain ya, the LP needle specific, and then it is 90 degree. Basically kena in tadi position ya, position of the patient, and then ada some degree of angle juga, because if dia very near the next next vertebra, will get some blood from there, because the vessel will be above the vertebra. Apa lagi ya? Tadilah the technique is there ya. Any question for it?
Doctor, I have question. Usually I have two questions. The first one is it crucial for us to take the pressure? Because previously I had seen this procedure lumbar puncture, but there's no checking of the pressure. Okay, and then the second one, usually we took the pressure before we took the culture, before we took the CSF, or after? Thank you, Doctor.
Okay, so basically we the pressure meter yang direct to after we inject the needle tu, it's difficult to get lah. Even me never use yang this pressure meter. Usually we just evaluate the sign of the increased ICP kan, because increased ICP is the contraindication. So we just evaluate any sign of increased ICP, such as papil edema, some degree of lateralization, and so on and so forth. So yang direct measuring the pressure tu saya pun tak pernah buat. Yang just buat ya before we do the procedure, we make sure there is no sign of increased ICP. Sometimes if possible ya, if available we can consult ophthalmologist, but sometimes easier we check by ourselves and just use ophthalmoscope, see any papil edema. Okay, is it your question or anything else?
Doctor, is it the pressure we took after we took the fluid or before?
Yeah, before lah.
The pressure?
Yeah, before.
Before. Oh, okay. Thank you, Doctor.
Yeah, any other questions? Tak ada? Sudah 5 kan ya? Already 5 presenter ya? Nampak
Yes.
Azri, okay. We take a break first lah. Kan nak continue, but I think another 5 lama juga. we need to take a break, and then I offer you, we will continue after this, or we get another day maybe, because another 5 ya another 2 hours man. Lama juga. Yang mana? Nak continue je? If you can do it 5 minutes aja, boleh lah. Maybe 30 minutes selesai. Tapi kalau lama ni, dekat 2 jam juga tadi kan.
Kena tanya presenter dulu.
Boleh Doktor, sekejap je.
Oh boleh. Tapi lah saya kena break 1 or 2 minutes ya. Ya. Saya kena discuss with tak apalah, continue lah. Alright. Hello, continue.
Okay. Siapa present? Fiza.
Hello. Dia nampak. Nampak. Nampak.
Nampak.
Nampak. Nampak tak?
Nampak.
Nampak.
Okay. So now we're going to learn about how to use inhaler and spacer in pediatric patient. So method dose inhaler, MDI, is a handheld aerosol device that uses a propellant to deliver the therapeutic agent. This is spacer and this is the mouthpiece. And a spacer is an external device that is attached. This one, a spacer, an external device that is attached to metered dose inhaler to allow for better drug delivery by enhancing actuation and inhalation coordination. So there's the spacer will mana this spacer, it will permits the aerosol fume from the inhaler and allow the particles to slow down, turning it into very fine mist instead of high pressure actuation spray. So it and this is the mask. So here is a video on how to use inhaler with a spacer. Allah. So step 1, remove the inhaler cap and check for Allah. Remove the inhaler cap and check for any foreign objects in the Okay, check for any foreign objects. If there's no any foreign objects, then insert the inhaler into the spacer and make sure the air chamber forms a good seal around the inhaler. And then the step 3, shake the inhaler for 5 seconds. And then step 4, stand up straight, tilt head slightly back. And then step 5, breathe out completely away from the inhaler. And then step 6, place mask firmly over the face. Step 7, press down the inhaler once. And then place mask over the face while taking 5 to 6 deep breaths. And then ask the children to take 5 to 6 breaths. And then step 9, remove the mask. Then rinse mouth with water and then wipe the face with a damp cloth. Uh, Hello, can you hear?
Yes.
Okay.
Proceed.
So when using inhaler and spacer for children, we need to give advice for parents. The first advice that we need to give to parents is first check your child's inhaler and spacer technique. It is especially when first time using it. So to make sure that the child is using it properly. And second one is to check the child if the children is using the right inhaler and spacer or face mask, and make sure they are using the correct inhaler and face mask appropriate for their age. And then the third one is wash the spacer once a week by soaking in lukewarm water with mild detergent for 15 minutes and rinse it well. This is to prevent bacterial contamination in the spacer. The fourth one is do not brush or using cloth while washing the spacer, because this will create an electrostatic out in the spacer. The electrostatic force will will cause particles of the medication to attach to the walls of air chamber instead of going to the airway. And the fifth one is air dry the air chamber. Do not dry it under the sun. And the sixth one is replace spacer at least once per year. That's all. Is there any question?
Udah. Color lah. Yang untuk pediatrik, color apa? What color? Siapa? Hafiz ya? Kalau pediatrik color apa?
Tidak ada.
Untuk pitch color apa?
Color of
Di chamber lah.
chamber.
Or
Spacer.
spacer.
Yellow.
Kalau infant, yang kecil lagi color apa?
Infant orange.
Okay. Nah. Dan teknik tadi? Ini apa saya? Or how many second untuk one puff?
20 seconds.
20 lama ya. Usually 5 to 10 second cukup lah. Okay, yang lain any questions? Okay, dah, thanks. Next.
So next presenter will be Akmal Saad.
Ya, Assalamualaikum. Next, I'll be presenting about feed flow meter. Yeah. Wait. Ay, ini. Ya. Can you see the screen?
No.
Sorry.
No.
No.
Yes. Okay, Akmal. Video okay, audio tak okay, mic tak okay. Sama macam Far tadi kot agaknya.
Oh.
Nak tunggu Akmal masuk balik ke proceed dengan presenter lain dulu? Syed.
Next presenter dulu lah.
Okay.
So next we move to Lina.
Assalamualaikum.
Salam.
Waalaikumsalam.
Kejap Sebab saya tak boleh buka. Kejap. Nampak ke skrin? Can you see the screen?
Yes.
Nampak?
Okay. I will be presenting about IV line incision and also venipuncture. First, the indication of IV line incision is when we want to take blood sample or there is need for intravenous fluid, medication and also nourishment to be given to the patient. So the contraindication of IV line incision is when there is extremities with broken bones, or there is site of swelling or edema, compartment syndrome, site of previous infiltration, as well as open wounds or broken skin. Okay, so for the site of IV line incision is to the superficial vein, and this is the equipment that is needed, which are intravenous catheter, Pegadum tourniquet, saline flash, positive pressure caps, board tips, and also hand sanitizer. So first, the techniques is choose IV catheter, which is to be given according to the age of the patient, size, and also the condition. Usually the standard size is size 24 to 20 gauge. So First, open the alcohol pad and then open the T connector and prepare the saline flush. And then attach the saline flush to the pressure cap and prime the cap with the prime cap is a safety feature to prevent backflow of the blood from the vein or air entry into the vein when the T connector is not clamped. So after that, you can open the transparent film dressing, which is the tagatum, and then use hand sanitizer and wear glove. Okay, for the technique, after you already sanitize our hand, find the vein through visualization or the palpation. Okay, then after you visualize the vein, apply the tourniquet and make it like a small loop. After applying the tourniquet, prepare the skin by applying alcohol pad. And then you can start to insert the IV catheter. So the direction of the IV catheter must follow the direction of the venous blood flow. And when we insert the catheter, the needle should face upward with a degree of 25 to 30 degree. When there is already the presence of blood into the catheter, we can remove the tourniquet and we can remove the tourniquet and advance the catheter off. Advance the catheter off and apply advance the catheter off, apply pressure and then remove the needle. Then you have to, if you want to take a blood sample for the lab, do not flush yet. Take the sample first, and then after that only you flush the catheter to check for patency, leaking, redness, if there are any blanching or swelling. And then apply occlusive dressing. Apply occlusive dressing and then secure the incision with tape or armband. Don't forget to also write the date, time, and also IV size on the tape. And then later we have to do hourly assessment for is there any phlebitis, bleeding, or extravasation at the site of the incision. That's all.
Okay, yeah. Any questions?
No, doctor.
I think okay ya. So far clear ya yang Lina dah last pun dah malas nak go over detail kan. Dah penat sini. So far simple je lah untuk IV learning session. Color apa? Yang color of granula apa? Lina, ada tak you show the colors?
Kalau for 24 gauge tu warna dia kuning.
Yes, usually basic yang infant tu pakai yang yellow, but kalau bigger child pakai apa yang lagi besar?
Blue kan?
Biru ya. Kalau yang smaller dan yang yellow ada tak?
Smaller than yellow. Orange.
Tahu.
Violet.
Untuk donor, untuk blood donation color apa? Ada yang pernah ini? Donate darah, derma.
Donate tapi tak tengok jarum.
Tak boleh.
Seram.
Yeah. Rasa yang grey kan yang lagi besar tuh. Mana? Kita boleh next presenter.
Hello, Assalamualaikum. Can everyone hear my voice?
Yes.
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 Alright. So for my part, I'm going to present the procedure of pediatric ECG. So ECG must always be interpreted systematically to minimize the risk of missing important abnormalities and find out the problems that the child might has. ECG interpretation usually start by determining the heart rate and rhythm, the P wave, the PR interval, the QRS complex, ST segment, as well as T wave. As you can see, the picture illustrates the relevant component of the conduction system, the heart with the ECG waveform. We have already learned that there is an action potential that discharged by SA and AV node that generates electrical current and give rise to classical ECG waveform. The activation of atria is reflected in the P wave, and meanwhile the ventricles is reflected in the QRS complex. So when do we need to perform ECG? ECG is indicated when there is cardiac history or family history of sudden cardiac death, any cyanotic condition, if there is loss of consciousness or seizures, any drug injection or poisoning, any dysrhythmia such as sinus arrhythmia, tachycardia, or paroxysmal supraventricular tachycardias, and also indicated for chest pain on exertion. To perform ECG, normally 12 leads will be used to record the electrical activity of the heart. The chest or precordial leads are placed on the same anatomical landmarks as adult, but in infants and toddlers, because the right ventricles are more dominant, an additional lead 4, additional lead V4 on the right side of the chest is added. This is the normal values in children. Usually the child has higher heart rate than the adult. The higher the heart rate, the shorter the PR interval. But bear in mind that it is normal finding. As the child ages, the heart rate will slow down normally. You guys can refer from pediatric protocol. Moving to the ECG characteristic, in neonates, the ECG is similar to the adult ECG with right ventricular hypertrophy. So this ECG is an ECG of 2 days old infant. As you can see, Q wave, the Q wave depends. The Q wave is seen and at the lead 2, lead 3, AVF, V5, and V6. This Q wave depends on amplitude and duration. If it present in the lead V1, but absent in the lead V5 and V6, then it is considered pathological or abnormal. There's also right axis deviation. If you can see the lead 1 and lead 2 or lead 1 and AVF, where there is also dominant R wave in the lead V1 to V3. This one, V1 to V3, and also deep S wave in the V6. The dominant R wave, we can see in V1, V3. This is because of the relative large size of the right ventricle. There's also maybe an RSR prime pattern. If you can see the mouse, RSR prime pattern with narrow QRS in V1. This is called incomplete right bundle branch block. If there is a wider QRS complex, it is called complete bundle branch block. In lead V1 to V3 also, we can also see the T wave inversion, this one. It is considered normal when there is T wave inversion in children, and usually it may persist until adulthood. If the T wave is upward, we might suspect right ventricular hypertrophy. Next is the in neonates heart rate. As I mentioned earlier, is faster than in adult. For cardiac output in neonates, because of smaller stroke volume, the cardiac output of neonate is maintained by the fast heart rate. Next is the ECG of 4-month-old female. You can see there is sinus rhythm and with less right axis deviation. It is because this infant, this ECG of the infant is starting to become normal, like normal when it entering the next phase. The R wave remain dominant in V1, and as well as R to S ratio in V2 become close or less than 1. T wave also is inverted, still inverted. Next is toddler. The ECG belongs to 2 years old male. The QRS axis is less than 90 degree now, and R wave still starting to be dominant in the V6. R to S ratio in V1 is becoming less than 1. This one, as you can see, the R to S ratio in V1. The R wave becomes smaller than the S wave. Next is lastly the late childhood to adolescent. This ECG belong to 8 years old male. The QRS complex is progressing to become adult in the precordial leads, which is V1, V2, V3. And then during this time, the left ventricle becomes more dominant as the child enters the adolescent phase. And as you remember, the neonates ECG just now, the R wave is more dominant in V1, but in adolescent, the S wave become more dominant in V1, and R wave become more dominant in V6. It is like neonates entering adult phase. The T wave is negative in the V1, but as I said earlier, it can persist into adulthood. This is case example. I will read to you guys. So a 12 years old male athlete is brought to ED by his parent after he experienced chest pain. Upon arrival, he has reproducible chest wall tenderness. The parent insists that he received an ECG because a local middle school athlete recently died during a sporting event. The ECG is noted to be abnormal by the machine and the concerned parents. So what is the next step in management? So bear in mind, it is ECG of 12 years old male with chest pain, and there is reproducible chest wall tenderness at the ED. So the answer A, must obtain at least 2 set of cardiac enzyme value. B, obtain cardiology consult in the ED. C, refer for 2-dimensional echocardiography. D, reassure the patient and his parent. And E, admit for observation. So this is the ECG. So as you can see, there is sinus rhythm as the P wave appear before the QRS complex, and the heart rate is the heart rate is actually 1, 2, 3, 4. The heart rate is 75 beat per minute, not 100 beat per minute, and that is normal axis of lead 1, lead 2, and lead LVF. And as you can see, there is T wave inversion in V1, V2, V3. As I see before, T wave inversion is actually normal from the neonates and persists to adulthood. So the answer is D. So the patient, we must assure the patient and his parent that it is normal to have T wave inversion in 12 years old male. And that is link that you guys can see later on how to place ECG lead on the baby and how to approach to pediatric ECG. So this is my references. I think that's all. Any question?
I have a question.
Yes.
From the ECG part, from the case,
Yes.
okay, the ECG, the case, okay, from the case, is there any abnormalities other than the T wave inversion?
You can see there is sinus arrhythmia, but it is considered normal because no, it is normal. It's normal.
So my question is, what is the things that induce the chest pain, and also what's means by the reproducible chest wall tenderness? Can you clarify this?
Reproducible chest wall tenderness. I'm not sure, but I think it is when the patient arrive at the ED, the pain still going on. I'm not sure. I will find it later and share
Simple
with you.
actually on off apa chest pain. Actually it is on off chest pain is common in children, and then the 70% cause actually is not cardiac. Even though it is chest pain, it is not cardiac. Most likely it is musculoskeletal problem. So that's why the pain is on the chest wall, the muscle musculoskeletal problem there actually.
Okay, thank you.
Doktor?
Sorry?
Yang musculoskeletal problem tu costochondritis ke bukan benda lain?
Yeah, one of the causes costochondritis. Can also other problem, trauma boleh.
Okay.
Or apa? Tak pernah exercise, sekali buat exercise sakit semua, chest pain juga.
Okay, thank you, Faria. Now we move to our last presenter, Akmal Saad. No, we cannot hear your voice.
Hello, I think okay lah. Karena no limited data tak apalah. So just submit je, walaupun yang lain sama, submit di slide please ya, yang lain. Please submit the slide. If possible, direct to Google Classroom tuh. Kalau tak boleh, can upload in WhatsApp and then biar Kak Farah yang ini, yang upload in Google Classroom.
Doktor.
Yes.
Rasanya kita orang bagi Kak Farah kot sebabnya sebenarnya kita orang dah upload lah tapi masing-masing tak nampak orang lain punya file. Saya upload, saya tak nampak orang tak nampak. So kita orang bagi Kak Farah kot.
Boleh lah kok. Maybe setting kok. Because I don't see as well. Kalau setting dia boleh common macam share file ya boleh tengok semua. Okay. Akmal tu apa tadi di topik? Pictometer senang. Ya, yang penting patient can obey the command following instruction. Usually 5 years boleh, but usually school age lah 7 years. Yang penting deep inhalation and then deep force expiration itu je. Okay, any question?
No, Doctor.
Tak ada?
As for now, no.
Irsyad boleh close the session.
Okay.
We have another session kan nanti ke? Ke dah habis dah?
I think for this week, no more.
Following weeks lah. Ada lagi kan? I think should be 2 or 3 times lah jumpa saya.
Oh, I don't check.
Okay lah, alright. Nanti communicate in WhatsApp group Irsyad mana? Nak tutup ke? Boleh?
Okay, so we close our class today with tasbih kafarah dan salatul asr. So thank you, Doctor, and my friends.
Thank you, Doctor.
Thank you. Assalamualaikum.
Thank you, Doctor.
Thank you, Doctor.
Sorry semua banyak masalah kita. Tutup lah.
Okay, bye guys. Thank you. Sorry for the technical problem, guys.
Sorry juga. Kesian korang.